We will now cover a stapled side-to-side anastomosis. The video is running at twice normal speed, so it's just whizzing through a little bit, but you can go back over it. It's a fairly straightforward anastomosis. I'll just flash the two staple guns which will be used. One's a linear cutter and the other's a right-angled cutter, which we'll talk about when we're doing the join. So you can see a loop of small bowel in the video frame. It's got a devascularized bit which my right hand's on, and you can see the mesentry's disappeared, or the mesentry's not there. That simulates what happens when you start to do resection. Effectively, you divide the mesentery and you can see the two cut ends, if you like, of the mesentery. You can see the one on the left hand loop in front of you. The bit which is devascularized, so the loop of bowel without the mesentery, is a bit that's going to be removed. And so that will have either the ischemic segment or the lesion or whatever it is that's being removed. So I'm just first of all making an enterotomy. We make the enterotomy just within the devascularized section of bowel. So we don't want to lose bowel which is viable. So don't make the enterotomy in a bit of bowel that's got a blood supply. You make a small enterotomy just beyond where the mesentery attaches, or where the mesentery gets to. So it's a devascularized piece of bowel. You then get your linear cutter. Most linear cutters have got a thinner leg and a fatter leg, if you like. This is a small bowel to small bowel anastomosis, so it doesn't really matter which one you put in which. If you've got a size discrepancy, if you're doing a small bowel to colon anastomosis, then put the thin leg in the thinner lumen, and vice versa. So you can see we've inserted the linear cutter in, and the important thing is you've got to rotate the bowel around. You've got to make sure that the mesentery around the back is not incorporated in between the blades of the linear cutter. I'm just using a scalpel handle there to push the mesentery back out of the way, and then I put my finger behind it just to make sure there's no mesentery being caught within the jaws of the linear cutter, and then close the linear cutter. Most linear cutters are designed so once you've closed them, you leave it for 15 seconds until you actually fire it. When you're doing this kind of anastomosis, you can use that time to put a little safety stitch in at the crotch of the join, and it's called a crotch stitch or something similar. I normally do 2 of these. So this is getting a muscular bite of both loops of small bowel just at the extent of where the linear cutter is going to staple. It's just because that's the bit that's at risk of unzipping if the anastomosis is put into tension. So I put a single stitch there. I normally put a second stitch as well. Once you've done that, you fire the cutter forwards and back, depending obviously on the type of cutter you're using in terms of whether it's from one company or another. They're very similar in terms of the mechanism. And then what you need to use is your right-angled cutter. This is an Ethicon, it's a TX right-angled stapler, and this goes across the enterotomy. So on the healthy side of where the enterotomies are being made, it goes across both loops of bowel, so that the 2 holes that you made for the linear cutter are incorporated in the bit that's coming out. You want to make sure you don't catch mesentery in this, and that's then fired. And depending again on the brand of the cutter, it either cuts as well as firing, or you end up having to cut the bit of bowel that you're removing off with scissors or a scalpel. So that's the loop of bowel which has got the pathology in it, which has been removed. Eventually, my scissors aren't sharp enough. It's a familiar situation. So that's the loop with the pathology, whether it's a small tumour or a perforation or an ischemic segment. I'm now just trying to tidy that up to make it look neater because of the blunt scissors. And then what you're left with is an anastomosis between the 2 loops. You can feel, I just use my fingers there to press through, you can feel the defect between the 2. The staple line where I've cross stapled sometimes can bleed a bit, so I normally put a little hemostatic stitch. So this is just in the floating ends of the anastomosis. I don't go beyond the staples which are being put in with the right angle stapler. I just go right on the very edge of that staple line, and this is just a running stitch with a vicryl or braided or monofilament, doesn't really matter. And this is just often I use a locking continuous stitch over and over along this edge just to stop any bleeding, just to make it look neater. This is not to reinforce a staple line. If you're using staples, trust the staples. It's my philosophy anyway. This is just really hemostatic, just to stop any bleeding. Sometimes the staple devices are not as hemostatic as you'd like. Once you've done this over so, then that's your anastomosis constructed. So that's a side-to-side stapled anastomosis. It's an anti-peristaltic, so you can see rather than the bowel going in the same direction, it's actually turning back on itself 180 degrees. That's using a linear cutter and a right-angled cutter. And that can be a side-to-side small bowel to small bowel, or it can be a side-to-side small bowel to large bowel, like an ileocolic after a right hemicolectomy. Because it's side-to-side, size discrepancy between the lumen of the bowels is not as much of an issue, in the same way that it's not when you do a hand-sewn side-to-side anastomosis. If you've got a loop of small bowel and a loop of large bowel, the size discrepancy isn't really an issue. And you can use either a 75mm cutter or a 100mm cutter to make an even bigger anastomosis. So you can use the cutter of the appropriate size to make the anastomosis as wide as you need it to be. And that's the finished product. Thank you.